All right, welcome. Today, we're diving deep into urinary tract infections. We're going to cover all the high-yield info you absolutely need to know for your PEBC exam, all the way from the basic principles to those really tricky treatment decisions you'll face. So here's our roadmap. We're going to start with fundamentals, then tackle the most common case, uncomplicated cystitis. After that, we'll ramp up the complexity, do a deep dive on the drugs themselves, and wrap up with two super important areas, special populations and how to handle those frustrating recurrent infections.
Okay, first up, UTI fundamentals and goals. We have to build a solid foundation here, get clear on the core ideas and what we're actually trying to accomplish with treatment before we get into the details.
Now, this is a classic exam question, so listen up. What is the difference between a relapse and a reinfection? A relapse means the same bug came back, which tells you the initial treatment probably didn't fully work or there's a hidden source. A reinfection, that's a whole new ballgame, a brand new bug. Knowing this difference is huge because it tells you whether to just retreat or to start digging deeper for an underlying problem. So what are we trying to achieve? Well, it's way more than just making the patient feel better right now. As pharmacists, we're looking at the big picture. We're trying to stop the infection from getting worse and traveling to the kidneys. We're trying to stop it from coming back. And, this is absolutely critical, we're trying to protect high-risk patients, especially in pregnancy, where a UTI can become really dangerous. All right, let's move on to managing uncomplicated cystitis. This is your bread and butter UTI, the one you're going to see all the time in community pharmacy. You have got to know this inside and out. Okay, so here's the typical picture. You've got a female patient, her urinary tract is structurally normal, and she has those classic symptoms. That burning pain, feeling like you have to go all the time, you know the ones. Now, for your exam, you have to remember the main villain here, E. coli. It causes up to 90% of these cases. And here's another key point. You usually don't need a urine culture right away. For these simple cases, we treat based on the symptoms. And this table right here, this is pure exam gold. You need to know these first-line drugs and, just as importantly, their durations. But look closely at SMX/TMP. There's a huge catch. It's only first line if your local E. coli resistance is under 20%. If it's not, you're reaching for nitrofurantoin for 5 days, or that super convenient single-dose phosphomycin. Okay, we're leveling up now. Let's talk about complex UTIs and pyelonephritis. We're moving beyond a simple bladder infection to something much more serious. The stakes are higher, and our approach has to be a lot more aggressive. So, when you suspect pyelonephritis, your first job is to figure out how bad it is. Is the patient stable? Can they keep down oral meds? If so, that's mild to moderate, and we can probably manage them as an outpatient. But if they have a high fever, signs of sepsis, or they can't stop vomiting, that's severe. They need to be in the hospital getting IV antibiotics, period. And that one decision, inpatient or outpatient, completely changes our drug choice. For those mild to moderate cases, we can use an oral fluoroquinolone because it gets into the kidney tissue really well. But for a severe case, someone in the hospital, we're pulling out the big guns, IV drugs, like an aminoglycoside, maybe with ampicillin just in case. Now, let's be really clear about what a complicated UTI is. It's not about how bad the symptoms are. It's about the patient. Do they have a catheter, a kidney stone, some other structural issue? Or are they male? And that's a key takeaway for your exam. Any UTI in a man is automatically considered complicated. This means we have to think about a wider range of bacteria, and it means a urine culture before you start treatment is non-negotiable. All right, time for a deep dive into pharmacotherapy. Let's really get into the nuts and bolts of the drugs we use. This is our toolkit, and as a pharmacist, you have to know these agents like the back of your hand. So let's start with our two workhorses for simple UTIs. For SMX/TMP, that 20% resistance number is a hard line in the sand. For nitrofurantoin, there are two things you absolutely must remember. One, it does not work for pyelonephritis. It just doesn't get into the kidney tissue. And two, you can't use it if the patient's creatinine clearance is under 30. That is a hard stop. Next up, we have phosphomycin, which is just awesome for its simplicity. One dose, and you're done. Then, on the other end of the spectrum, you have the fluoroquinolones. Look, they're powerful, no doubt about it, especially for pyelonephritis. But their use is getting more and more restricted because of resistance and some really serious side effects. And that leads us to a crucial warning you need to know about. Here it is. This is the official word, and you need to burn this into your brain. The message could not be clearer. For a simple, run-of-the-mill bladder infection, the risks of using a fluoroquinolone are just too high. They are a last resort for this kind of UTI, only when you have absolutely no other choice. This table, you're going to want to screenshot this one. These are the key adverse effects you have to link to these drug classes. C-aminoglycosides, think kidneys and ears. Fluoroquinolones, think tendons. Long-term nitrofurantoin use, think lungs and liver. SMX/TMP can spike potassium. And carbapenems carry a risk of seizures, especially if kidney function is poor. Let's shift gears now and talk about special populations. This is so important because when you're dealing with a patient who is pregnant or breastfeeding, every single decision you make has to be carefully weighed against the risk to the baby. Okay, let's break down pregnancy. First, a huge principle. Even if there are no symptoms, if we find bacteria in the urine, we treat it. We have to prevent it from turning into pyelonephritis. Now, what do we use? Cephalexin and fosfomycin are good choices. But what's even more important to know is what not to use and when. SMX/TMP is a no-go in the first and third trimesters. Nitrofurantoin should be avoided right at the end of the pregnancy. And fluoroquinolones, they are off the table for the entire pregnancy. Now for some good news. When it comes to breastfeeding, our options open up quite a bit. Many of the antibiotics we use for UTIs are considered compatible, which gives us a lot more flexibility than we have during pregnancy. All right, on to our final section, managing recurrent infections. At this point, our mindset has to change. We're not just trying to cure one infection. We're trying to develop a long-term strategy to prevent the next one and the one after that. This flowchart is basically your playbook. First things first, you have to confirm the patient actually meets the definition for recurrent UTIs. That's 2 or more infections in 6 months or 3 or more in a year. If they do, then we start thinking about prevention, about prophylaxis. And the strategy we choose really depends on that patient's specific situation and triggers. So what are our options? Well, for a patient who's reliable and doesn't get infections too often, we can give them a prescription for self-therapy. If the infections are clearly linked to sex, then postcoital prophylaxis, 1 pill after intercourse, is the obvious choice. If they're just happening all the time without a clear trigger, we might have to use long-term, low-dose daily antibiotics. And this is really important. For our peri- and postmenopausal patients, we should always be thinking about vaginal estrogen. So I want to leave you with this final thoughts. We've talked a lot about drugs today, but with antibiotic resistance becoming a bigger and bigger threat, our role as counselors has never been more important. Teaching patients about non-drug strategies, things like staying hydrated or avoiding spermicides, that's not just nice advice anymore. It's a fundamental part of antimicrobial stewardship, and it's absolutely essential to good pharmacy practice.